TopMedTalk.
Well, hello, I'm Desiree Chappell, and this is TopMedTalk. We are coming to you with our continuous coverage of the COVID crisis from the front lines. And we're going to have these conversations, or we've been having conversations with providers all over the world who are either on the ground themselves taking care of COVID patients, or they're playing a very supportive role in this battle against coronavirus. Now, we're going to continue to share these stories in hopes to provide education and support to everyone out there who is dealing with and taking care of COVID patients. Now, I'm joined by our editor-in-chief critical care physician in London, England, Monty Mythen. Hello, Monty.
Hey, Desiree, great to see you.
It's great to see you too. How are things on the ground in London, Monty? I know I keep asking you for updates, but I think it's really important to get that global perspective.
It's still weird from the point of view of being this city that's usually so buzzy and everything going to have pretty much everything shut down. You know, we get access to drive in and we still get to go to the familiar places, but, you know, you can park anywhere. There's no traffic. You get in and out to work quickly. In the hospital, as I keep saying, my colleagues are working incredibly hard and doing a fantastic job. We hope that we have peaked out on our surge. You know, there's great debates today at government level as to how long this plateau will turn into that lasting for a long time. And now we're dealing with the very complicated discussions about when should we reopen things, the impact on the economy, the impact on people's sanity for being, you know, locked up at home. But then the really difficult numbers we've seen this week is a rise in non-COVID deaths in the UK adjusted for what we expect to happen at this time of year. And that prompts the debate. Are people in the general healthcare system getting substandard care? And that's what I think we're going to talk about a little bit later. You know, we've restarted scheduled cancer surgery, for example, but maybe our patients aren't as well prepared as they would have been before. And maybe some people are staying at home and sitting on top of their tummy pains and their chest pains and not presenting to their providers. So that's the new discussion for this weekend.
To talk about that a little bit further, and again, to get a feel for what's happening here in the U.S., we have our next guest, who is a friend of the TopMedTalk family, a superstar on TopMedTalk from Chicago, USA, is Dr. Bobbie Jean Schweitzer. Hello, Bobbie Jean. How are you?
Hello, Desiree and Monty. It's my pleasure to be here, and thank you for that very, very kind introduction. You guys are definitely my friends.
That's right. And I introduced you as doctor, but you are professor of anesthesiology and the director of perioperative medicine at Northwestern University in Chicago there.
Yeah, my title's changed a little bit.
Oh.
I got either a promotion or just more work. I'm not the associate chair for clinical perioperative practice, I believe is my official title now.
Oh, fantastic. Congratulations.
Oh, thank you. Didn't come with any more money. It just came with a little bit more work, I think.
Better parking, better improved coffee. I mean, those are no?
Can you just give a little bit of background and explain those titles just a little bit more?
Sure. So I have a background. I'm trained in both internal medicine as well as anesthesiology. And I've spent my career in the initially preoperative space and trying to evaluate and optimize patients for that concentration is on the higher risk patients or the higher risk surgeries. And I spend half of my time working and directing a preoperative clinic and half of my time doing actual anesthesiology in operating rooms, offsite locations. I do everything except OB and cardiac anesthesia. No peds either anymore but everything except peds, cardiac, and OB. And with my new sort of roles, I've been just trying to expand further into that interop and postoperative periods. We've always felt that we've sort of in the preoperative world pushed more and more that, you know, we're not happy anymore just getting the patient to the operating room door and having the case not be canceled. We now want to make sure that they have effective care and coordination of care through every transition. So into the operating room, out of the operating room, into the recovery space, and even looking beyond, you know, minimum of until they get discharged and even into the, you know, post-op 30-day period and increasingly at a year out, because I think it's all about needing to prove that what we do has added value, results in better outcomes, better processes of care, save costs, something that's sort of objective measures of effectiveness.
Can you tell us a little bit about your anemia clinic and how it functions right now?
So a little bit of background, because I think, you know, when you talk about anemia clinics, they're all a little bit different. You know, we set up an independent clinic embedded in our preoperative clinic that would allow us to effectively and efficiently diagnose patients who have anemia and then diagnose the underlying cause of that anemia, and then offer them treatment for that anemia. We implemented our first infusions in January of 2017. It was about 6 months to a 9-month planning process to get that all set up. It's in part and embedded within a whole perioperative blood management system. So we worked across the board with our pharmacists and our blood bank and our hematologists, our surgeons, our anesthesiologists, in trying to, design the best fit for our institution. I think that's important because I think, different institutions have different resources. Some already have places where patients can go and get these infusions, but they just struggle with, getting the patients sort of identified early on, particularly when you're talking about a preoperative population. Others, don't even have that. So, I think every institution, if they're interested in setting these up, needs to look at where the need is and look at the different components. So we felt like we needed to both improve our diagnosis of patients. We needed to improve timely evaluation of these patients, but we also needed to improve their access to actually be getting these infusions. Because even though we had several infusion centers in our institution, they were really busy giving chemotherapy, which had a priority, and then ironically giving blood transfusions to patients because they never got their anemia treated, right?
Yeah.
So we, started out just offering it to pre-op patients. We expanded that to OB patients, and we even expanded that to a few non-sort of OB or pre-op patients because there was a need. And so even before the COVID pandemic, we had started to really ramp up our services. In fact, we've given over 3,700 iron infusions in the last 27 months.
Whoa.
Yes. We've published now, a couple of papers describing our processes. One was just in the March issue of Anesthesiology, where we described our process for diagnosis, which I think is very important.
Bobbie Jean, before you get to that bit in a second, because we've managed to set up some wannabe iron clinics in our institution that then haven't quite got to the level that you've got at, and we were starting to get traction. One of the tragedies of what's just happened now is as COVID-19 has destabilized our elective surgery, we've rebooted cancer surgery, and we're seeing patients coming in who haven't had access to the iron clinic. Have you managed to mitigate that in your population?
Yes. So that's one of the things that's changed with COVID. So we argued very much that we needed to keep our clinic open, even in fact, increase the resources for the clinic. And we partnered with our blood bank and with our administration to increase advertising of our clinic and push that out. And we also expedited the ability not only to diagnose, but then give these infusions, hopefully with just one visit, so that patients don't have to come back. We can get the results back within a relatively short period of time, an hour or less for most of our patients. And in the past, where it took some time to get the authorization from insurance companies and the drug actually prepared by our pharmacists, we've worked to streamline that entire process. And we've reached out very much to our non-surgical colleagues to increase their awareness and education around both our diagnostic testing process, which is this one-step single situation where you can diagnose the presence of anemia and then diagnose the underlying etiology, if it be vitamin B12 or iron deficiency.
And that's what that paper that you put out in March was talking about, that.
Yes. So that was described in detail in the March issue of Anesthesiology. So I do urge people to take a look at that if they're interested, because I think that is also very much key here, because we want to limit the amount of times patients are coming back, right? And then also because of certain procedures are very time sensitive or relatively urgent. You don't want to delay even a day or two of delaying the diagnosis and a day or two of resetting them up for another appointment. And then many patients, don't even have the same access they would previously. They don't want to take public transportation. Their family members can't come and get them and drive them because now they're being isolated, or they're workers that are being actually asked to work more. So we realize that it's important to look at the kind of barriers that we perhaps always had to some degree that have been much more magnified now in this COVID pandemic, and new barriers to getting patients effectively and efficiently both diagnosed as well as treated. We've also expanded our iron infusions. The other day, I gave an iron infusion to a patient intraoperatively because it was a patient that we had diagnosed preoperatively who could not come back and get their iron pre-op. And she was having a cancer procedure. And what was also unique about this is that she was almost certainly going to have some further procedures. So we thought it was very important that we give her. So we gave her a ferric carboxymaltose infusion intraoperatively.
Well, Bobbie Jean, there at Northwestern, I mean, I would imagine that it's not necessarily business as usual, but I mean, there's still urgent, emergent, and scheduled cases that you have to be able to facilitate.
Everything is just upended in how we are trying to manage things. Many of our staff from our preoperative clinic have been pulled to provide care other places, both physicians as well as our advanced practice providers, our nurses, more urgently needed on COVID units or in the ICUs. So we've been trying to be good citizens in that way and, revamp how we do. Plus with the decrease in elective surgeries, there was some decrease obviously in the patients that we were seeing or needed to be seen. We were already doing preoperative phone screens and some telemedicine for some of our patients. We've just increased that dramatically. We had already started to allow some of our advanced practice providers to work from home and do these. So we've also just expanded that. And it's been an opportunity to sort of just streamline those processes because it's all about, like how you get patients scheduled, how you reach out to them, how you manage those, schedules and those phone calls. It's been a little bit easier for us to actually do the phone screens for patients because we find them at home.
You're not chasing them like
exactly.
normal.
They're actually in their homes now, so they have time to talk to us. In fact, they're often happier to talk to us because
I'm sure they're like, please talk to me.
I'd love to be screened.
So we've done that, but we've also we had already set up, like I was saying, some of this. We were one of the leaders in our institution of using remote screening of patients and telemedicine. So we've shared some of our expertise with our medicine colleagues and other people, our surgical colleagues, so that they can, utilize some things we had already developed and adapted. And a lot of that gets down to things like, just simple things, sometimes like a template. You have a set way of making sure you ask certain questions and get through it in a timely fashion. What we've more recently started doing just this week is we've started anticipating for our resumption of normal scheduled surgeries, our elective or, the surgeries that have been delayed. And we have a huge backlog, as you can imagine, patients. So we've developed and starting to develop now a system where, we are trying to reach out to everybody with a phone screen, even when they do not have a surgery scheduled. So we contact them and we ask if they're still intending. This is off the canceled or delayed previous list. And we're reaching out to them and asking if they're intending to have their surgeries, at Northwestern, at our institution in the future. If they say yes, then if they have time right then, we do a phone screen. If they don't, we set them up for an appointment for a phone screen. And we're going through that, and then we're evaluating them. And these were patients that previously we perhaps would have brought in. But now we're trying to gather, information, like maybe they had their stress test already, but it was 2 years ago. It's even from an outside institution. Now we can start working on gathering that information, right? If the patients we feel need to have blood work done for their surgery. So example is a major spine case. We would order the blood work right now. Now, granted, we don't have an OR date, so we don't have the patients coming and get that blood work done. We just put everything in; it's ordered. We give them their instructions about their, what to anticipate next steps, even their medication instructions, which we push out through MyChart, which is a mechanism we can do easily through, our EMR. And now we flag that patient's record. So if and when they get on the schedule and they have a surgery date, the normal mechanism would be either for the surgeons to call into our scheduling office or the patient to call in to make an appointment. Now it'll be clearly shown when they call in that this patient's had a phone screen already, that they have orders outstanding, and they can be instructed to go and just have those orders done. We'll reach out with another, hopefully quick phone call after we look at those lab results, and perhaps that patient won't even need to come in at all. And now they can be just sort of fast-tracked into coming in and having their surgery, because we expect not only a surge in backlogged cases for the ORs and procedure rooms, but then that will lead to a surge in our demand for our services.
Absolutely.
So we're trying to upfront work on these things to get some of this stuff out of the way or done ahead of time.
Bobbie Jean, are you noticing or taking the opportunity to work with patients that are much higher risk? So maybe you're not getting blood work, but you know that they're, have nutritional or functional capacity issues that you can already start tuning them up for the potential surgery, knowing that as soon as things resume that they will be probably at the top of the list?
So that's an excellent question. There's always silver lining in every cloud, right? And I said that this is sort of a forced time lag, especially here in the United States, where, somebody wants to have their surgery tomorrow's too late, right?
Yeah.
I can't have it this afternoon.
Yeah, exactly.
I have to wait till tomorrow.
Yes.
And so, that's always been one of the challenges that we have in preoperative medicine is that we don't have that time to actually improve and optimize patients. So this is giving us that sort of forced time, right? Now we can perhaps do things and patients are more accepting of that. While you're waiting to be able to get on the list, be scheduled, let's address these other issues. And, sort of to circle back to our anemia thing. So yes, so now address your anemia and have actually enough time to see appropriate rises in hemoglobins that we perhaps before would have gotten either, pushback from the surgeons, pushback from the patients, or at least some angst around, are you going to delay surgery, postpone surgery to fix this a problem? And yes, and all along with, whether it be nutritional optimization or even, getting patients and keeping them, physically fit or having them do things. I know there are some platforms for, prehab where you can, patients can monitor their own steps and report back. We're working on some of those. We don't have a lot of those in place. Again, we were, had anticipated doing a lot of this even before the COVID hit. Now it's sort of forcing us to be a little bit more, interested or pushing that timeline up. Unfortunately, again, we're crippled by a lot of our resources are being used other places. Yeah. And in fact, even a lot of our technology optimization and our telemedicine endeavors that we had hoped to do, we've lost some of our technicians. We've lost some of our computer and admin people who were helping us with that.
Now people have got the time to engage in the opportunity to get themselves ready. Are they engaging enthusiastically or is it mixed? Because sometimes we accuse our patients of no matter what opportunity we give them, some people won't engage.
I think it's both. I think, we're seeing at least more patients who are willing to even listen to these options because, in the past often it was like, but are you going to cancel my surgery? Or, or like, well, what do I have to do? Or, so now I think that we're at least having patients, be interested in, and some of them are finding more time on their hands. We also find, though, the opposite, too, that some patients, even though it appears that maybe, you would have more time on your hands because, you're not working, it's hard to sort of just be navigating daily life, right? It takes longer to get certain things done. Like if you go to the grocery store where you have to, you have your mask and you have to clean your stuff. And now many people who would go out to restaurants and eat or have a delivery are cooking for themselves. They're cleaning up for themselves, right? Yeah. They're often supervising children at home who they're become the kids' teachers now. So I think that not everybody does necessarily think I have all this extra free time and headspace or I can do this. Some of our older patients, I do think that they are very interested and more eager about this because they do find they have a little more time on their hands and they're a little bit bored and they've watched enough Netflix now, or they don't even know how to get on Netflix. I'll do my exercises now. I'll actually, monitor my blood sugar and report it back in.
It's the most interesting part of the day.
I know.
Yes. And they're actually willing to take our calls, we're someone to talk to.
Yeah. Do you have any pointers? I would imagine that it's still going to be a little while before we get things up and running and really a long time until back to normal.
And there'll be a lot of support for the reboot, we get the impression. So if people are trying to say, I couldn't get my administration to engage in the opportunity, we're getting the opposite feeling here. We're saying, no, this is the chance to go at it because we've got a big backlog of stuff to do. Tell us how to get it done quick.
Yeah.
I agree. Use this opportunity if you do find yourself having some free time and you've been one of those anesthesia or perioperative physicians that was more involved in taking care of patients for elective surgeries. And so now you're not doing those. Use this opportunity to say, let me start to work on these initiatives that I want to do. better is always the enemy of good. Start with some small things.
Yeah.
And if you do find yourself with a preoperative clinic that's somewhat empty and you haven't been having patients come in because they're not seeing elective cases and you've got some nurses and providers staying around, is see if you can't repurpose some of those people and your clinic space to, start to do some iron infusions. And the backlog of thinking, we've got to do this work anyway. I've often felt that we inconvenience a lot of patients by having them come into see us, right? The only reason to have a patient in front of you is if you need to lay hands on them and examine them with a stethoscope or your hands, right? You can even look at them. I can do an airway on you right now, Monty. I can do an airway exam right now. And
what do you reckon?
You can ask people questions.
It's the bad news.
Yes. In fact, we make it harder for ourselves and patients by having them often come to us and talk to us. Because I bring the patient in and I start to ask them about what medications they take. And they say, well, I don't know. My pills are at home.
That's so true.
Right?
Yes.
So you're much better off, I've always said, of talking to patients when they're there with their pills at home. You just have to realize that often one size doesn't fit all. Maybe the call is the first step. Then you triage that patient. And can be much like an emergency room is set up, right? The patient comes in and the ones who are dying immediately go back to the level 1 trauma center part of the ED. The ones who just seem to be like they're doing okay, have a few complaints of a runny nose, get triaged to sit down and wait. And if they, still are alive 8 hours later, they may be seen. If they haven't left the ED, they may. So, we need to triage and think through those kinds of things. What is the most efficient, effective way to do what we need to do? Really think about defining what your goals are, defining the population that you can best serve, and work with your own institution about, what are the resources you already have? How do you build on those resources? And how do you fill in gaps that aren't there? So I think there's a lot of things that this has helped us think about and prepare for. And definitely, don't wait till we open the floodgates for all this elective surgery to come at us.
In our COVID-19 patients, we are seeing extraordinary high levels in some of them of ferritin.
Sure.
Is there any reason why that might be happening? And there's this suggestion that they might be getting ferroptosis. In other words, they're getting injury from the ferritin as a result of part of the disease process.
I have seen that. And I think that it is not surprising that these patients would have high ferritin levels. We've known, for some time that ferritin is an acute phase reactant, right? And it goes up in inflammation, either acute or chronic inflammation. It goes up in serious illnesses. In fact, you never want to measure a ferritin level in anybody who has sepsis or who's in ICU. So the good thing about ferritin is if it's low, the patient's iron deficient. It's a good, cheap test. If it's high, it doesn't tell you anything. Okay. So that's why I urge everybody to, look at our PPAE paper that was published in Anesthesiology, because we talk about that a bit and we talk about the other tests. And basically, you're looking at something like transferrin saturation levels. So that's why we have this reflex testing so that we're not relying on a simple or one test. Now, there's no evidence whatsoever that I know of in non-COVID patients that high ferritin level has prognostic information about their disease or their level of, sort of like where this iron is at or not at in their body, because part of it is iron is a very complicated, whole multi-step process to get from your, exogenously, either through your gut into your bone marrow. And it's got to get to the bone marrow and then into the red blood cells. And every step of the way there's different, components that can be affected. And I think that the latest sort of focus in the research here is on hepcidin levels, because that's what appears to be what happens with acute illnesses and chronic and acute inflammation, is that you have these elevated hepcidin levels, which then have an impact on transportation of iron from the periphery into the bone marrow. That is perhaps one of the key focuses of research to help figure out where all that, what it means and how we can impact that. But don't rely on the ferritin levels on those patients to rule out iron deficiency in COVID or any other acutely ill patient.
That's a good point.
And we have another paper pending with ANA. It's actually been accepted for publication, just not out yet, describing our initiatives around our anemia clinic in the COVID pandemic.
Great.
Great.
Anesthesia and analgesia.
Yes, it's an anesthesia. Analgesia has been accepted, so I don't know when it'll hit the actual, airways. But look out for that because it helps describe some of the things we talked about today about, how to promote your anemia clinics in the COVID pandemic era.
Fantastic. All right. Well, Bobbie Jean, thank you. Good luck in everything that you're doing and especially in this reboot, because I know that you're going to be crazy once we get going.
Yes. It's always a pleasure to talk to both of you, and it's good to see you both well.
Yeah.
Great stuff. Thanks very much.
We'll catch up with you soon. Bye.
TopMedTalk.
Bobbie Jean, as always, thank you so much for chatting with us. And thank you to our sponsor, Edwards Life Sciences, for their generous support of our continuous coverage of COVID-19 from the front lines. Thank you for listening. We are here for you, our listeners. We want to support you. We're going to get through this. So please stay safe, stay well, and we will catch you next time.